So as it says, I'm an anesthesiologist. I did a pain fellowship and work for Legacy doing pain management. I've been doing that for about 10 years. And the more I do it, the more I know that I don't know. So I'll hopefully just let you in on my journey as I've been trying to be a little more effective with the folks that are experiencing persistent pain. So no financial disclosures. This is me at work, by the way. As I took on this topic about the mechanisms of chronic pain, what I find is a large volume of information out there, and it often is, it feels like trying to drink out of a fire hydrant. There's so many channels that you could go down, and there's so many different perspectives that you can actually look at this. But I really want to focus on one aspect of this, and this is to really understand pain as an output of a kind of a complex processing system that actually overlaps nicely with addictions and some of the things that we already went over. Biopsychosocial factors that are important in this experience of persistent pain, treatments, and then finally modality delivery. Like, how do we actually put together a treatment plan that seems to work? This is kind of a hot topic. We spent a lot of time last night in my clinic trying to figure out how we're going to actually deliver an integrated care plan. So what I'd like to start with is just how we experience pain in the real world. We experience pain really in an adaptive model, right? I'm walking along, I bump my leg, I have a painful experience, it's just letting me know I've been injured. I put my hand near a hot stove, it's a little uncomfortable. If I put my hand on the hot stove, what I'm gonna see is a lot of tissue damage, right? So way up here. And this is, was explained really in the ancient times as, you know, the gods casting down you know, pain on an unsuspecting sufferer like Job. But René Descartes in the 1700s, he's a philosopher, he says, no, I don't think that's how that works. I think what happens is you have a stimuli here, the fire, and it pulls a cord that goes into your brain and releases a valve. So that's kind of the beginning of this. And we actually continue to think of it just like that. We have some fancier terms. We've done a lot of research around it. Books have been written about it. But here we have a gentleman who is experiencing low back pain. The first thing we think of is that there's something wrong in his back, right? So we've got a disc, or we've got a facet joint, maybe some muscles, but something's stimulating a nerve, just like Descartes' fire. And we actually have done a lot of research around this, which, and we've called it transduction, the movement of one form of energy to another form of energy. And it can be thermal, mechanical, chemical, and this is where the inflammation occurs. And so what I do as an anesthesiologist is I'm going to put some steroid around that and do some injections, maybe see if I can calm that tissue down a little bit. And maybe even interfere with transmission, which is really how the free nerve endings are moving information to the spinal cord. It's quick with the A delta, or it could be slow with like the C fibers. And when that doesn't work, we start to do some fusions, right? We're going to distract those discs, going to stabilize that segment. That's going to get the pressure off the nerves. And when that doesn't work, we're going to go with the modulation piece, which when the impulse comes to the lamina, it gets transitioned to the dorsal horn. And so it ascends the spinal cord, and we can actually interfere with that, by modulating the dorsal spinal cord. And I don't think you can see this super well, but this is actually a spinal cord stimulator here. So the gentleman's had a fusion. He's had injections for sure. He's had the spinal cord stimulator placed. And that was okay. He was getting some pain relief, but we can even modulate it even further. We're going to put in an intrathecal pump. So this pump is actually running dilaudid. So an opioid actually will come sit here in the lamina and actually suppress the ascending signals. So the dilaudid is about 100 times more potent in the spinal segment than if he were just to take it orally. And when that doesn't work, we add pills. So this is actually a patient of mine. I inherited him a little bit like this is how I get my patients, right? The things aren't working. When the injections didn't work, the surgery didn't work, the spinal cord stimulator didn't work, neither did the intrathecal pump. And now he's not on oxycodone, he's on morphine. This is a guy who has, actually severe depression. Last time I saw him was probably about 3 or 4 weeks ago. He said his wife had to hide ropes because he constantly thinks about having to or kill himself. So complicated. Legacy patients. But a really decent gentleman. It's been a pleasure taking care of him. So this is the adaptive model applied to chronic pain. And what we're finding is that over the last 20 years, it doesn't really work. So this is a set of slides from Dio, who did a review of Medicare claims data. And he was saying that over the last 20 years, we're seeing marked increases in opioids, injections, and lumbar fusions to the tune of hundreds of percents. And the question is what are we getting out of all of that? Well, it's hard to know because we don't really keep great data. But what we can say is that there was according to the US Medical Expenditure Panel Survey between 1997 and 2005, which by the way are the same years that Dio was doing his research, was that despite the rises in all of these procedures and medications, we weren't seeing anything but an increase in functional limitations, mental health disorders, work and social limitations. As a matter of fact, part of the ACA was to task the Institute of Medicine to do a review of chronic pain in the United States today, and it really did not bode well. But what has happened is a public health crisis, and I think Jim went over this exact same slide. Rise of deaths associated with the sales of opioids. And unfortunately, this is just the tip of the iceberg. And that we'll save for a different slide. The problem is that tissue damage doesn't equal pain intensity. And we can look around and find some examples. This is a surfer in 2011 in California who was out catching a wave, got attacked by a great white shark. He says, I knew I was hurt, but I couldn't feel any pain. NCAA tournament is coming up. This is an open tib-fib fracture. He says, it was one of those things where I couldn't believe it. I honestly didn't feel pain. He actually had no idea what had happened until he saw his leg with his own eyes. But this is actually pretty old news, right? Beecher is who reported in JAMA in 1956 as he was caring for the World War II veterans, said, listen, compared to civilians, soldiers for the same injuries needed 5 times less morphine for the exact same kinds of injuries, and they had far fewer complaints. But we can also have the other occur, which is that you have no tissue disruption, like nothing's going on, and yet pain intensity is really high. And this is actually more common. This was a classic kind of historical example of this is phantom limb pain. The body part is gone. There's no sensory information that's ascending the spinal cord. Matter of fact, you can block the spinal cord, and the person will still have severe pain. But it's even a more common example is fibromyalgia, where you have tender tissues like joints, ligaments, and tendons that are often severely painful. But when you look for pathology, it's not there. And these patients have often been dismissed. What we need to remember is that persistent pain conditions correlate very poorly with tissue damage. So when someone is coming in with long-standing low back pain, it's unlikely that there's some fix that's going to be able to completely relieve that. I saw this slide, and I thought it helps illustrate the point nicely. This is osteoarthritis of the knee. It basically is our kind of favorite mechanical pain kind of example. The way that we grade osteoarthritis is through a four-grade staging system. This here is bone-on-bone pain. Fully up to 50% of patients who have radiographic osteoarthritis actually have no symptoms. And those that have absolutely normal x-rays actually can have severe pain, up to 10%. And when they looked at what are the differences, psychological factors really didn't explain all of that. And when you look at how to treat it with nonsteroidal anti-inflammatories, Tylenol, or opioids, they're really not all that effective. And up to 20% and 25 to 30% of knee replacements continue to have moderate to severe pain despite having the whole joint replaced. So what explains this wide differences between tissue damage and pain intensity? Ronald Milzak, who did the gait control theory of pain, the McGill Pain Questionnaire, and also developed the neuromatrix theory of pain. And this is what I want to help explain to you as far as I understand it today. Basically, he said our entire brains are made up of neurons, right? So these neurons are organized into modules. These modules then are further organized into networks. And the whole system is called the body self neuromatrix. For pain, the modules that are important are the sensory modules. So that would be the somatosensory cortex. The cognitive model, so that would be the prefrontal cortex, memories, and then the affective, which is the emotional modules that make up the limbic system. And inputs come from signaling systems. So they do come from the periphery, a free nerve ending. They ascend the spinal cord, hit the thalamus, and get redistributed. They also come from our gut. Those are being processed in parallel with cognitive related areas of our brain. So memories and attention are being processed at the same time as our signaling systems. And then also the emotional regulations related areas, the limbic system is also very active during this time. So you could see that, that these modules are processing in parallel. But not only are they processing in parallel, they're also interacting with each other and changing each other's processing. And the result of this is an output. Right? The output is going to be pain. It's going to be pain intensity, character, location. It's going to be an action. What I'm going to do about it, both volitional or automatic, reflexive. And it's going to activate a stress regulation program like cortisol, norepinephrine, endorphins, and the immune system. And this all happens instantly without a lot of effort on anyone's part. It's the way that we're made. These modules interact with each other through patterns of impulses called neural signatures. Neural signatures is just a coordinated pattern of neural impulses. And these patterns emerge, much like other areas in nature can emerge. So if you think of like a swarm of insects or ants or a swarm of birds. This is a video that looks like pirated. This shows a swarm. This is a murmuration of birds that are forming a pattern. And the pattern exists is to help them find food and forage safely. And what makes up this pattern is that they all have equal status, that it's the interaction between these players that cause the pattern, and that a change in one of the players can have a drastic change in the pattern itself. This has been taken further by a lab at UCSF where they were combining EEG. So this is a person wearing an EEG cap and using a gamepad who is looking at an MRI. And they combine this with a gaming system, allowing the person who is wearing the EEG with real-time impulses moving around the brain in 3D imaging. So the impulses are live. What you're seeing there is live. And she's able to maneuver around the brain with live impulses. So this is kind of where the science is going. This is what we're doing. And it's no joke. Because, it's not my next slide. Because a lot of good articles are being published, and I'll share one with you later on down the line. I just wanted to summarize that basically we get input from three areas: our somatosensory cortex, or our sensation, cognitive area, and our limbic system. And they continue to interact with one another in parallel and change one another through neural signatures that start to form larger neural signatures, which result then in an experience that is multidimensional and includes action, including stress regulation. So where are these areas? I like this slide because anatomy has always befuddled me, right? Like I'll have a hard time remembering things, but for Star Trek fans, I get this, right? So there's Scotty, he's there at the thalamus, right? He's gonna make sure everything is, going in the right area. Captain Kirk, you want him on your side in a fight, right? And of course, Spock, who's at the logical level, planning level. So this is Tom's world, is how he remembers stuff. So this is an fMRI. We've been talking quite a bit about it. There are several neuroimaging modalities that allow us to have a better understanding of exactly how these modules and portions of the brain interact with one another. It takes advantage of differences in blood flow. As it turns out, the brain, when it's active, uses a lot of oxygen, so then it diverts blood to the neurons that are most active, and they start to light up on processed MRIs. The most important areas in pain control is the somatosensory cortex, where it does discrimination, intensity. It's like, where's the pain coming from, and really how intense is that? The insular cortex, which is an integration center between both the limbic system, the somatosensory cortex, and the cognitive areas of the brain. It's where empathy occurs. So if you empathized for the guy with the broken leg, that was your insular cortex at least being partially active. And the anterior cingulate cortex, where it registers unpleasant feelings, whether they're coming from physical or emotional, like rejection. There are other areas that are important as well, like the prefrontal cortex, again, part of the cognitive module. The medial prefrontal gyrus, which helps you focus attention, particularly if there's something negative. And the right orbital frontal cortex, which does evaluations of stimuli, particularly if fear is involved. So it connects with the amygdala, like we saw on slides earlier. The thalamus, other areas that, which is the switching station, brings information from the periphery and redistributes it to the appropriate areas of the brain. Other areas I didn't talk about was like the perioccipital gray area, which is chock full of endorphin producing neurons and the amygdala. So this is a slide from the New England Journal of Medicine where a psychologist named Wager and his colleagues out of Colorado were doing experiments with functional MRI imaging, and they were able to differentiate between thermal pain, pain anticipation, and rejection. Right? So just using imaging alone, they were able to tell the differences, and they could predict what the pain intensity was with just imaging alone. So this was as close to a Dolar meter as we have, or we know of. Just as in addiction, the chronic pain states represent a different state of the brain. With prolonged exposure to stimuli, the somatosensory cortex and the ACC not only become bigger, but they start to move to both hemispheres. And we think that that's what accounts for this widespread pain with variable intensity. And as the insular cortex gets bigger, we start to move to more emotional aspects of the pain experience. The insular cortex also becomes more widespread and is thought to be important in the development of hyperesthesias or allodynia. Another slide about how a persistent pain brain is actually quite a bit more active. There are also long-term changes in receptor sensitivity and concentration, as well as gene expression. The cure responsiveness rate tends to decline as compared to acute pain. And you start to see behavioral and cognitive changes as well. So as they were talking about the fields, neurons that fire together, wire together, there are also some genetic determinants about pain sensitivity. These are the volume control as to how intense my pain will be is probably initially set by my genes. But then as I'm exposed to the environment around me, there'll be neuroplastic changes. And as it gets exposed to certain hormones, my pain intensity may also become different. The higher the pain control, of course, the more pain you'll feel. Or the higher the pain volume, the more pain you'll feel. We don't live in a bubble. This whole matrix actually has to exist in an environment. The environment has lots of opportunities, but also lots of threats. Social determinants of chronic pain, physical environment, early childhood development, culture, income, all play a role in the degree of pain that we experience. I was going to give an example of this. I was working with someone who had who has persistent myofascial pain, probably from fibromyalgia. Pretty stable. She was on some modest doses of medications, and we were just kind of moving along. She was doing some participation in like pain skills and information classes. I've been working with her about a year, and I sit down to talk to her one day, and I'm looking at the intake forms. She looks like she's doing a lot better. She's doing a lot better. I was like, wow. So tell me, why are you doing a lot better? And she said, I divorced my husband who was abusive, and I'm in a different environment, so I actually feel a lot better. So not that divorce is the cure. I don't want to say that, right? It's just that the importance that our environment likely has a much greater role to play than do changes to medication levels. Social determinants of pain, we know that social health is directly tied into physical health, that integration, activities, support, and I said environmental stressors over there, and our relationships, it directly impact the rate of cognitive decline, our susceptibility to infectious disease, our ability to rebound from medical conditions when they do occur, and we tend to live longer with better social health. So in summary, persistent pain and tissue damage are not equal. particularly in persistent pain, tissue damage and pain intensity are not directly related. That the neuromatrix theory of pain probably is our best explanation at this time as to how this works, where we have inputs coming from the sensory, cognitive, and emotional areas that cyclically process and imprint their neural signatures on one another to develop an output, which is pain perception. And the outputs become new inputs. The social and genetic factors play a role, and that there's a famous kind of pain researcher who has this quote. He says, "Pain is an unpleasant, conscious experience that emerges when the sum of all available information suggests that a body part needs to be protected." I like this because this is the same researcher that did this. Comes from his training program, Leomore Mosley. Basically, this shows how in persistent pain states that the contribution coming from central processing problems become much bigger, and the peripheral processing becomes a lot smaller. So in terms of bang for your buck, we probably should be focusing on these areas. Best outcomes come from treatment in multidisciplinary or collaborative care models, and actually I'm seeing this kind of grassroots efforts. You look at a lot of the county clinics in like Southern Oregon. This is old news to them, right? They're putting this all together. That patients need ongoing evaluation, education, and reassurance. We need to set reasonable goals. And you know, when somebody's saying, all I need is my oxycodone 40 milligrams 3 times a day, I'm going to be okay. I know that's probably not a reasonable goal, because I know at the most that's going to give them some reduction and may actually make things a lot worse for them. So treatments on average, no matter what treatment you said, I just really appreciated Jim's slide, where what can we expect from our treatments? 30% decrease. That's about all we can expect for almost all of the treatments that we have, except for ACT, acceptance and commitment therapy, which may have actually a better result. But even 30% is not. I mean, if you're having pain, if I have pain, I'll take 30%. I just want it to be safe. Daniel Claw is kind of divided this up into 2 categories. He said peripheral versus central. As you can see, the peripheral is really where you have mechanical forces or inflammatory forces that are most common in like pain settings and trauma. Yes, they're still there for osteoarthritis and rheumatoid arthritis. We tend to see this in older populations, and non-drug therapies that tend to work are physical therapy. Drugs that seem to work for acute pain, including non-steroidal anti-inflammatories and opioids, still appropriate. Injections and surgeries can be of good use, and we should use them. But when the central pain state is making up most of the problem, it's an amplification problem, and we should be working on ways to help settle that central nervous system down. Very common in things like fibromyalgia, headaches, irritable bowel syndrome, interstitial cystitis. This is the most common form in persistent pain, just like in Mosley's slide here. Most of it is the central processing. Non-drug therapies seem to be sleep. So let's see, overactive nervous system needs some rest. And so focusing on sleep and activity. Not even exercise. Let's just get moving. The activities of daily living and interventions tend not to be all that helpful. I like to think of all treatments in terms of whether they're active or passive. Passive treatments would include anything that somebody does to you or for you. So that would be surgeries, injections, acupuncture, chiropractics, medications. I'm not saying any of those are wrong, actually. Those are all helpful in the right context. Active treatments are anything you have to do, you have to put in effort for. So that would be things that get your body moving, and that would be things that get your mind moving, like pain education, cognitive behavioral therapy, acceptance and commitment therapy, counseling, recovery. Those are all important. What we like about the passive treatments is they're fast, they're effort independent, and they're generally covered. Like you need a medication, you likely are able to get some coverage for that. While active treatments tend to be slower. They take months and years, effort dependent, and they are often not well covered. Passive treatments tend to be pretty temporary. They tend to be bridges, and they reinforce an external locus of control, where active treatments tend to be more long-lasting. They tend to help bring in an internal locus of control. We had an expert in the room who experiences chronic pain every day. This is a lot of what I heard was the control came now from within. So, didn't mean to call you up. I often tell my patients that my expertise is really limited, right? I'm not the one that experiences the pain. In many ways, they are a much better expert on their experience than I ever could be, or ever I want to be, right? So this is a slide regarding medications. I thought it would be helpful to just review where these medications work. I'll try and go through it really quickly. It's important. This is an important slide because it tells us what the important neurotransmitters are as peripheral processing occurs, and that is glutamate, substance P, and inflammatory cytokines. The descending pathways can be inhibitory or they can be facilitatory. The inhibitory neurotransmitters, by no surprise, is serotonin, norepinephrine, GABA, and opioids. And of course, the facilitatory neurotransmitters, glutamate, aspartate, and serotonin. I was going to leave that off because it's not as cut and dry as we'd like to think. So opioids, again, work brain and the spinal cord. The nonsteroidal anti-inflammatories work to inhibit cyclooxygenase and reduce inflammation. Antidepressants work to elevate serotonin and norepinephrine. These, again, are in the inhibitory pathway. They may have some effect on NMDA receptors and mu receptors as well. Antineuroleptics. All antineuroleptics that we use for pain generally target glutamate. Try to reduce it. The strategy for Lyrica and gabapentin are really by blocking calcium channels that do this. Tegretol and Lamictal block sodium channels, and then valproate bind to GABA receptors. Muscle relaxants, in general, they are divided up into benzodiazepine type of muscle relaxants and non-benzodiazepine. The ones that we generally see for persistent pain are non-benzodiazepine, and most of them are just central nervous system depressants, with the exception of baclofen, which binds to presynaptic GABA, and tizanidine, which binds to alpha-2 receptors. Cannabinoids, there's a lot of booming research on cannabinoids at this point. We know that they inhibit mast cells and can indirectly stimulate opioid receptors. They also seem to have an inhibitory effect on glial cells that may be important in developing persistent pain states. Capsaicin causes a release of substance P from the free nerve ending, and most commonly used in the postherpetic neuralgia or nerve-related pain. NMDA antagonists, again, target glutamate-gated calcium channels. So this would be like memantinine, dextromethorphan, even ketamine and methadone work partially this way. Just for a review, opioids, nonsteroidal anti-inflammatories, antidepressants, antineuroleptics, and muscle relaxants. I always tell my patients really there's only 5 classes of pain medications plus an other, and I kind of go through that list. The most time they come to see me, it's for this one right here, the opioids. it's the most potent. It's the one they've been exposed to, and it seems to give them that, what they remember. If they can only make this one work better. So based off of the work that Portnoy did in the mid-'80s, he basically took a small sample, I think it was like 36 patients on fairly low doses of opioids, and was able to maintain them, I want to say, for about 6 months, but not super long. And he was able to demonstrate that, this is a graph where you have pain, this is more pain, hyperalgesia, dysphoria. This is euphoria, analgesia, and this is time. And he was saying that you could kind of get this normal pattern over time. But in real practice, what happens is we tend to see euphoria and analgesia, and over months it starts to peter out. And this is about the time that we have to talk about what to do about it. So we really only have a couple of options. When you get to this point, you can either increase your dose, and you kind of recycle back here and go through this again, or you can come off, which tends to also help people have significantly less pain. The problem is that it takes a lot of time. And there are other components to this, because opioids do a lot of things in our body, not just help reduce pain. Other areas that help with improving pain are physical activity. So it does improve just general conditioning, improves the health of joints. So synovial fluid is produced with stimulation of the joint or movement of the joint. There are certain tissues that only get nutrients through movement, like our discs, mostly get nutrients that way. They can help promote relaxation, reduce flare-ups, improve mood, anxiety, depression, and release some endorphins. It also seems to be that exercise helps reduce the transition from acute pain to chronic pain. And we think that has to do because it activates opioid receptors in the descending pathway, and it can also release macrophages and anti-inflammatory cytokines, reducing receptor sensitivity. The affect regulation, or I call this physical therapy for the mind. Like I do a referral to behavioral health, or I try to get someone to consider working with I just call this physical therapy for the mind. So it starts really with pain education, information. I'm happy to hear Nora talk about this because this is so important. Pictures, examples, metaphors, trying to find ways for folks to relate to something that's pretty complicated. Hey, all I need is my oxycodone and I'll be fine. Cognitive behavioral therapy is another form of affect regulation, where you take unhelpful thoughts and behaviors that may contribute to increasing sensitivity, and trying to improve that with coping skills, self-efficacy, and change the way patients respond to their pain. Acceptance and commitment therapy. The fundamental tenet here is that pain is part of the human experience. We will all have pain, and that it is the avoidance of pain that causes suffering. So it uses a mindfulness-based approach where observing thoughts and feelings without judging them or trying to change them, and then having or behaving in ways that are consistent with your values, goals, and life direction. McCracken in 2004 developed a chronic pain acceptance questionnaire, and he showed that there's really two important aspects to this. One was the willingness to experience pain, and two, the continuing to engage in valued life activities even though you hurt. And what he found was that those that were able to do that had a lower pain intensity, less depression and anxiety, greater social and physical ability, less pain avoidance, and they had a better work status. And what was interesting, it wasn't that the people who had less pain had better acceptance. That relationship was not there. Sleep is essential. I think I covered that around how the chronic pain state brain is more active, and there are other causes of sleep, including just primary insomnia, restless leg syndrome, obstructive sleep apnea, and that as sleep worsens, pain sensitivity goes higher, which then progresses to worsening sleep, and it becomes this vicious cycle. Medications can be useful for this, but so can non-medications like cognitive behavioral therapy. It's hard for one person to just do this all. Like, this is too big for one doctor in 20 minutes to make a big impact. And I'm not saying that what you get here is going to be directly, like, you're going to know in 20 minutes how to help this person with persistent pain get better. But we do think that an integrated approach is probably our best chance at getting long-term reduction. And the data actually helps support this. And an integrated approach is really about a three-legged stool, which is we look at the medical problem that a person comes in. So yes, a person may have fibromyalgia, but have they had the blood work done to make sure that we're not looking at an autoimmune inflammatory process in the early stages that could be addressed with disease-modifying medications, and that we look to see that they're as medically stable and what can be fixed has been fixed. That there's a physical therapy approach. I put physical therapy there, but it's really the activity part, that we get movement of the body, and then the behavioral health was really around moving the mind, and kind of a physical therapy approach for that. I thought I could add, but I couldn't. I was going to add a case example. And the case I was choosing was somebody who was a 39-year-old who had fibromyalgia and obstructive sleep apnea, was on Tramadol, Cymbalta, Lyrica, and had a history of childhood sexual abuse, and is currently caring for, caring for 3 children, and does not smoke or use illicit drugs. So, like, what would an integrated approach look like for this person? Really, it would be, is this a legitimate diagnosis, fibromyalgia? And is that the major component of her pain? And just assuring that the medical workup has been done. The selection of the medications all seem reasonable. Tramadol, Lyrica, Cymbalta, we know can have effectiveness. For us as clinicians, and as we talk to our patient, we should know the effect size of that is probably not a lot. As a matter of fact, Tramadol can be sometimes problematic. People actually, it's listed as a non-opioid, but it works like an opioid. 50 milligrams of Tramadol is roughly equal to 5 milligrams of morphine. So just know that they could have withdrawal symptoms coming off that, not just for the opioid, but also for the serotonin and norepinephrine effect. It could interact with the Cymbalta as well, so you kind of want to know what the doses are there. The childhood sexual abuse, just know that this is an altered brain that you're working with. Right? This is not an acute injury, nor should it be treated like one. So respecting the possibility that this person could benefit from some physical therapy of the mind, and to what degree this has been addressed and what role this plays is part of the assessment. And then this idea here, no tobacco, alcohol, or illicit substance use. You know what that says to me is that the person actually has some internal coping skills. Like, these are readily available. She could turn to those, but has not. So there's some support system that has been going on, or maybe she had struggled with this and doesn't want me to know that. But anyway, these are things to assess. So in summary, just that persistent pain is this complex biological phenomena that has multi-dimensions, kind of best explained right now by the neural matrix as I tried to explain that. The best treatments really are about trying to get our minds and our bodies moving again, that we not just move to trying to reduce nociceptive input, which is likely to have a small effect, and that an integrated strategy is probably going to be our best approach. So, that ends my section. Do we have time for questions? Yes, we do. See, I told you that I would answer all your questions. Right? Yeah.
Okay. So, we were talking about this after Lydia's talked about trauma, and when are people, again, in an interdisciplinary approach, when are people ready for different types of interventions? So as Lydia was saying, for instance, it's hard to do, you don't want to do a certain kind of mindfulness practice, in your practice. Sometimes you want, a behaviorist to do that. I'm wondering if, because you work in a multidisciplinary setting, if there are certain times when you're able to sort of gauge, okay, I can't really work on physical therapy at this point because these other factors need to be addressed first. I mean, do you have a way of sort of doing your assessment so that you sequence the interventions in ways that make sense for where that individual is?
So the question is how to know when to do what?
I'm going to send you to behavioral health and physical therapy and work on your medicine.
Right.
The combination of these should be great.
And that's not, for me, that's not the very first thing. The first thing that has to happen is you have to hear the story. It's the validation piece. Got to hear that story, and you got to develop a relationship, because they aren't going to hear anything unless that one piece has happened. Right? So I think I have to check myself. So I'll do a chart review, and they look terrible on paper, right? Really terrible. And so I need to make sure that my attitudes are as much as I can understood, and that I validate that experience. They're not telling me, they're not making anything up, right? Like I actually think the brain is really active here. They're just telling me what they're experiencing, and they don't need me to say, well, you need to go to you need to go to physical therapy for your mind, because the initial impact of that was just another doc who's told me all my problems are in my head. So I think the validation piece is the first piece. The next piece is some really interesting work that we're starting to do under patient activation. Have you guys heard of this? Right? So we call it the PAM score. It's called the Patient Activation Measure. We're starting to implement a trial of that in our clinic to see if we can better meet patients where they are. They may not be ready to hear about physical therapy, about they just may need somebody to, they may be at like a level 1. They just need medication safety. That's it. That's all we can do. Right? And see if I can actually just engage there. And as we move through, for those of you that don't know, PAM is a 4-tiered level that measures patient activation. And if you have a low level of activation, you don't want to talk to someone about things they're not ready for. You may want to keep things very basic, really about safety, food, water, shelter, and do you have Narcan, nasal Narcan in your cupboard? That's maybe the best that you can do. Or you might even say, this is too much. This is a high-risk individual. I am not able to engage with this person that would be safe. I need them to work with my colleague, Melissa, right? Before I can actually start to engage. So that's how I think of it. So. Yeah.
You said you got to build a relationship and learn the patient's story. The first thing that came to mind was the video of Rachel's, sitting down with that patient, basically saying, "I want to hear your story," and then totally freaking out.
Yeah.
So, especially in a primary care practice where you have limited time, I don't think you're a specialist, probably an hour long.
I do. I have I'll ask her.
So let's get real here. So what kind of advice would you give primary care providers in terms of how are you going to learn the story? What are the key questions? We see people sequentially, and probably the chronic pain folks come in sequentially. What are the key? How do you gather that in an efficient way? What do you want to know? Because a lot of times we think we know our patients, and we don't. What are the key questions we should ask?
So generally, in my arc of the interview, I try to get to the heart of the issue in a 2 to 4 minute time frame. I have the luxury, right? I have the luxury of hearing it from the referring provider, right? So I already know what you think. It's when the primary care gets this cold. Like, you have somebody move from Texas who's on 400 milligrams of oxycodone, and they just need a refill of their medication. Like, how is a primary care physician supposed to handle that in 20 minutes? That actually makes no sense, and I don't think I could give you an adequate response. But I'll tell you how I try to do it in my own practice, which is try to get to the basic story within 2 to 5 minutes. I keep ratcheting up that time, don't I? But I try to get a sense as to, like, if they have low back pain, I'm going to try already know that they have had a lumbar fusion in 2011, another one in 2013, that they've been referred by their primary care because they've been actually running out of their short-acting opioid. So I'll be able to nudge that along a little bit more quickly, but I'll try to use motivational interviewing to get there as fast as I can. So, so I just use a very simple ORS, and I try to think about that. So open-ended questions, affirmations, reflections, and summations. And I try to run through that. And a lot of times I fall flat. So I have a few people in my office here. How often do we run late, right? All the time. I don't have a corner on that, and I wish I did. Good.